Hello and welcome to Lunch Break with the Village. I am Yvette Young, Associate Vice President of Training and Advocacy at the Village. We are so glad you could join us today. Please comment and let us know where you're checking in from or where you're watching from today. We'd love to know that detail. Our guest today for a very important conversation on our new Urgent Crisis Center are Dr. Laine Taylor, Medical Director here at the Village, and Amy Samela, our village's Vice President of Residential Services. Thank you both so much for joining us today. I am excited about having this conversation because, as we all know on this call, there is such a great need for additional mental health supports for our families and our children in our community. But before we dive into our conversation today, I just want to let our audience members know if at any point you have a question for any of our guests, please put that in the chat and we'll take the opportunity to answer that question before the end of the broadcast. So once again, if you have a question you would like to ask, please put that in the chat. Okay, Dr. Taylor and Amy, let's get started. There's so much to cover, so much information we want to make sure that the audience members have about our new urgent care center. So we're going to dive in and hopefully get through all the details that we need to today. So Amy, you're up first. And the first question is, the Village recently opened the first youth mental health urgent crisis center in Hartford. What is this new level of care?
Thanks, Yvette, for the question and for having me today. So what we know is both in Connecticut and globally, there continues to be a significant increase in children suffering from mental health. This was prior to the pandemic, and obviously it increased due to the pandemic. This led to a shortage of services, an overcrowding in the EDs, and significant wait lists. So committees were held to create this new level of care. So what is the UCCs? The urgent crisis centers are a diversion to the emergency room. So prior to the pandemic, through the pandemic, and after the pandemic to date, there can be upwards about 30 kids sitting in the emergency room. And we know only a small percentage of those kids actually need inpatient level of care. So that means kids are sitting in there for hours and sometimes days to get an assessment to ultimately go back home to the community. So this level of care is considered a diversion to the emergency room. So kids who are a lower level, suffering from a lower level of mental health, so chronic depression, anxiety, suicidal ideation, self-injurious behaviors that don't result in needing medical care, can come to the urgent crisis center to be seen by a complex group of interdisciplinary staff to get that level of assessment they would in the emergency department.
Excellent. So definitely in a continuum of care that we have in the state, when we think about continuum of care, we think about from prevention all the way to the highest level of intervention. We now have a place in that continuum where kids can have a mental health crisis, but not have to go to the emergency room for care or treatment, and can be triaged in a quicker time frame. Excellent. So how many of these now exist in the state?
So we have 4 urgent crisis centers in the state. They are strategically located. We have ours, obviously, in Hartford. Yale has an urgent crisis center that's located in their emergency department. And then there's 2 other community-based urgent crisis centers. Wellmore is operating one in downtown Waterbury, and Child and Family Agency of Southeastern Connecticut, located in New London, has the 4th.
So I guess I'm gonna do a follow-up question to that question. Is if I am out of your district, let's say, or out of the particular region, am I limited to being able to access? So if I live all the way in Willimantic and my child is in crisis here in Hartford, or I feel more comfortable coming into Hartford, do I have that option, or I have to go to the urgent care in my district?
Families can go to any urgent crisis center, whether it's closest to their home or one they prefer. We also know that we're not strategically located to other towns in the state of Connecticut. It could still take upwards of an hour to get there. So we are an option for them instead of going to the emergency room. But we know it's not the most convenient for every single resident in Connecticut.
Okay, excellent. So do I need a referral or an appointment to go into an urgent crisis center?
No, that you don't. So there's no wait list and no referral needed. It's as if you were going to the emergency room. So if you're experiencing any sort of mental health crisis or some sort of acute distress, you can just come on in and we'll see you.
Okay, excellent. And on average, what is the length of stay at a UCC?
That's a good question. As of now, we've seen about 40 plus kids and families, and the average length of stay is about 4 to 5 hours to receive that level of assessment and then get you back home.
All right, excellent. Thank you so much, but definitely a shorter wait than the emergency room would be. So
Absolutely.
I'm sure parents right now are elated to hear that they wouldn't have to stay the day and maybe overnight before their child gets released. Thank you, Amy, for giving us that sort of foundational understanding about what the UCC is, how do people get access to it, where they're located, and sort of length of stay when you do visit one. So Dr. Taylor, I'm going to pivot to you now and talk a little bit more about how is this service different and unique for mobile crisis, because a lot of us, especially if you're in this field, know about mobile crisis and their immediate response. What's the difference between them and the UCC?
Thanks so much for the question, Yvette. Yeah. Just as a quick overview, mobile crisis is if your child or youth is in behavioral health crisis, you can call 211 and have request that mobile crisis come to wherever you are in order to do an assessment. They can provide over the phone support as well as come out to you. I think the biggest distinction and most concrete distinction between an urgent crisis center and mobile crisis is that we're a physical location. So you would go to us. We do not come to you. But we do partner very greatly, very deeply with the mobile crisis agencies across the state in order to really partner and make sure that kids who might be better seen in person versus in their own environment, wherever they might be, would be able to get to us. And those who really need to be seen in their home, we're able to support mobile crisis getting out to them. An example could be a child who is struggling and there needs to be some brief separation from the environment or brief separation from the caregiver in order to de-escalate the crisis in the moment. That could be a good example of a child who would come to us instead of using mobile crisis.
Excellent. So let's talk a little bit about what behaviors or mental health presentation would require a parent to bring their child to our UCC. I know that if I was a parent and I had a kid at home and they're having maybe what I'm thinking is a tantrum, but maybe it's a little bit more than a tantrum, but I'm not really sure, I might decide, okay, well, let me take them to the hospital because they'll be able to help them there. Help parents understand what is it that they're looking for, what kind of behavior are they seeing that says, hey, get them to an urgent crisis center before it might escalate to something more and have to end up in the ED. But I think in general, I don't think most people know when should I actually access this service.
Yeah, just to make it really simple, as long as the kid isn't in a life-threatening situation, meaning that they've done something where their life is imminently threatened by harming themselves, or others haven't been imminently harmed by their actions, meaning they haven't actually really injured somebody such that hospital level of care is needed, then the urgent crisis centers are right for you, just in very simple terms. I think, we've seen the gamut. We've seen from, families that are brand new from another state, even Puerto Rico, that have not been able to figure out how to connect to care. They come in and they ask for support in knowing how to connect to behavioral health services to continue their medications, continue therapy, et cetera. We've seen kids who are, in fact, having thoughts about wanting to die, wanting to harm themselves, and may even have a plan around it, but have not actually harmed themselves and don't actually have any injuries or anything like that requires medical attention. We go the whole spectrum. And, if you have any doubt, as long as is more than first aid is, if there's not more than first aid needed to treat whatever is going on with the kid, then bring them in and we will support and help to determine where the right place is. That's a part of our triage system, is as soon as you walk in the door, you're able to see a triage nurse who's able to get a basic information to say, hey, yes, you're totally appropriate for this level of care, or we think maybe you do actually need to go to the hospital, and we'll provide safety and support until the ambulance is able to bring you there.
So speaking of it, you kind of answered the next question I had, which was what is the difference between, or what would be a crisis that would take someone to the hospital versus a UCC? And you did a great job talking about that imminent risk piece and that medical emergency on top of a mental health need. But would there be any time where a kid would be brought by ambulance to a UCC facility, or if an ambulance is called, it's an automatic, they go to the emergency room?
Yeah, at present, the legislation is not yet set up such that ambulances can divert kids over to urgent crisis centers instead of to the emergency department. That's active effort is going on in order to make that possible. But at present, if you call 911, you will be taken to an emergency department. So the child does have to be safe enough to be able to be brought to the urgent crisis center. And it occurred to me there's one other piece that we need to really explicitly say about who is appropriate to go to the urgent crisis center is you have to be 18 or under, or if the child is actually in DCF custody up to 21. But
Okay.
sort of just think youth, kids, 18 and under really is the population that we're serving. And the other piece is if there is a need where a parent is not able to be present and provide support, then that's going to be a requirement of us being able to work with the child, meaning we need to get consent from the guardian in order to provide treatment. We need to be able to make sure that the child is able to be taken back to their community location from us, because we are not a 24/7 program just yet. And our limitations are that kids aren't meant to stay overnight with us. So that's just another important clarification as well.
No, that's really good. Thanks for that additional piece of information. All right, so I'm going to turn to Amy, right? So we've kind of talked about like what is UCC, who is appropriate to attend, the difference between it and some of the other services in our system of care. So what can a parent or youth expect when they walk into our urgent care center?
I think that's a great question, Yvette. And I think one of the things that I always want to tell families and kids before they come into our UCC is they're going to come into a place that's different from the emergency room, and it's different intentionally. Emergency room, right? And Dr. Taylor kind of talked about just who should go to an emergency. It's chaotic, but when you walk into our urgent crisis center, it's intentionally the opposite. So you're going to be greeted with a person and immediately triaged, as Dr. Taylor just said, to make sure you're in the right level of care. But once you're received and it's agreed that you're in the right level of care, you're immediately going to be taken to a private room, separated from everybody else, where you're going to be met by a whole host of different disciplines to start the assessment. But each assessment is met by either a behavioral health nurse, a social worker, clinician, and then a registered nurse and a psychiatric provider. And each person is going to really spend the time getting to know you and getting to know what it is that's going on so that we can develop a comprehensive safety plan, connect to care, and get you back home. But in addition to that, we have additional staff that are really there to help families. So if I'm a parent who's having a conflictual relationship with my child and I needed to be separated, I have an opportunity to meet with a family navigator, family support specialist who's able to talk to me, validate, help me advocate for my needs and for my needs and my child's needs. And really what I always say, help me fill my bucket so that I'm in a different place so I can then be able to help my child. So there's this whole wraparound approach when they come into the UCCs. But the other thing that people will notice is that there's no beds, and that's intentional. We don't want families to feel like they're going to be sleeping there like they would in an emergency room. So there's, couches, chairs, really comfortable therapeutic furniture to help ground the children and really recognize that this is going to be a place for them to be for a short period of time and ultimately get them back home.
Excellent. So once the families leave, right? So they've come, they've triaged, you guys have connected them. What happens after the youth and the family leaves? Is there any additional support that our center provides for them?
Yeah, Yvette, I think one of the things that I like to say that this is the most unique thing that we can offer in the urgent crisis centers, which is really a lot of connect to care. So we spend a lot of time identifying services that will help the family and these children to safely be managed in the community. And sometimes it's creative things like music therapy, play therapy, or sometimes just a Taekwondo activity to help wrap them when they're back home. And obviously the traditional outpatient and other levels of care treatment. But in addition to what families can expect from us, which is the really key and unique piece, which is our aftercare services. So we know when kids and families leave an emergency department, and this is no disrespect to EDs, they're given a piece of paper of a referral to call them. And we know that they ultimately really tend to not call them and end up back in the ED. So we intentionally put in this really specific aftercare service where our staff are calling the families every single day until they've started that next level of care. So if I went to the UCCs, for example, at 7 at night, the staff who are calling me the next day are second shift staff that they can recognize, their voices are familiar to them, because we know if they're connected to us, they feel more motivated, they're more likely to follow through with those clinical recommendations.
Okay. And is it just clinical, or do you guys do all types of needs and services that the family might be dealing with at the time?
Yeah, so as I said, all sorts of services. So we get really creative where if a child's looking for a specific wraparound service, such as, like I said, Taekwondo, music therapy, art therapy, just dance. I mean, we've done some really creative things based off of what the interests are of the children. So no, not just clinical for the child, but also the family and the siblings if needed as well.
Oh, awesome. So that's fully wrapping the family tightly then. Okay. Excellent. This is for both of you. Can you share with us some successes that you've identified so far with this level of care? So we know it's new. We know that we're still ramping up and people are still learning about the UCC. One of the reasons why we're really putting a sort of spotlight on this program today, because it's hugely beneficial, but we're still spreading the word. But for the cases you have seen so far and the encounters you've had, obviously without identifying anyone specifically, just in general, what are some of the successes, the feedback that you're getting from families as they've come through the center?
Well, I can just,
I promised I would call one of you, so let me let Laine go, because Amy, that way you can rest your vocal cords a little bit.
Okay. Yeah, I think we've had a number of successes, and I think that those successes get borne out not only from a success from the interactions and the support that's happened in the moment. I think the de-escalation of crises, where parents will come in feeling just fully overwhelmed and fed up, and then by the time they leave, being able to feel like they have a good plan on how to support their child who's been struggling for quite some time, right? I think in real practical terms, we've helped with things like coming up with plans for kids to go back to school and be able to return to school safely when there's some school avoidance, going back to things like camp, things where there's avoidance, and being able to come up with a plan to really support that family. And then again, that gets borne out, as Amy pointed out, in the aftercare of ongoing support, assessment of the needs of the child, of the family, and also identifying what are the barriers that might come into play with accessing care. So you can make all the referrals there can be, like on every level of care in the state, but if a family A doesn't have the transportation, or if the family has other barriers that are really practical around childcare, things like that, and people aren't thinking about that or asking to address that, then it kind of makes it hard for you to even follow through, even though it's absolutely something your child needs behaviorally. So I think that's another piece of the success, is being able to be very holistic in the approach and identifying what barriers there could be to really getting the needs met.
Excellent. Amy?
Yeah, just to tack on to what Dr. Taylor says, throughout all of those aftercare calls, we're able to get a sense of how happy and how motivated the families are. And I use the word happy, but I think the other word that always sort of am attuned to is the word hopeful. Hopeful is a piece that we're really focused on. How much more hopeful are you with your child's success and his or her treatment? And I think that families are really able to identify feeling more hopeful, not just when they left, but really throughout those aftercare calls. And I think that that's really important. I think, we're collecting a lot of data. And the other thing that, when we're looking at success, we look at numbers. Are these families coming to us instead of the emergency department? And we're seeing that this is an emergency department diversion, and that we're able to keep children back in their home and using a very short length of time to be able to circle through. So I think that we have a lot of really good reasons to be hopeful in this level of care. And again, just not only in our 40 plus kids that we've served, we've only had to look at 3 who have needed to go to the emergency department. And those are for, a whole host of 3 different reasons, but ones that were able to go in a seamless way. So I think that with all of the successes that we had, not just with our families and our kids, but also with the partners that we're able to create here in this new system.
So, I mean, that's a really good transition to another question that I have, which is, sort of your interaction with the other parts of the continuum of care, right? So I know you have a navigator, they can identify resources and services, but when we're talking about clinical supports, like you said, there's some kids that may come in, they're not able to be stabilized. They have to go for an emergency room inpatient stay. How else are you communicating with different parts of the system, whether it's for, clinical services, group services, with, foster care, whether it's EDT, like how are you guys then making those bridges? And is that what you mean when you said, they follow up afterwards to make sure that that connection is made?
Yeah, so, prior to the program opening, we developed a lot of workflows with sort of all of those continuum level of cares that you're talking about, Yvette, whether it be, intensive outpatient programs or inpatient programs to EDTs and outpatient therapies, as well as inpatient level of care. We really wanted to build sort of that continuum within the resources that we have in Connecticut to try to create a seamless, sort of handoff and that warm handoff for the families and the kids. And that even goes to, and I use an example of even the opposite, whether kids leave the UCC and need to go to the emergency department, we have a really nice workflow and connection with CCMC so that families, for example, don't even have to be asked the same questions. We're able to communicate our assessments so that when they do end up in the emergency department, they already have the information to decrease families having to go through that again.
Excellent. Dr. Taylor, I saw you on mute, so go ahead.
Yeah, I think just to add to that, this is also about relationship building, right? And us being able to connect directly with other providers and other community resources in order to make sure that we have our relationships as we're helping to build and connect relationships for families. And so that's been an active aspect of what we've been doing out there, is doing a lot of outreach, a lot of communication. And even if the kid shows up and their pediatrician is, a part of their care, obviously for whatever reason, we're making sure that there's a direct phone call to that pediatrician, a direct phone call to the psychiatrist or the therapist, in order to make sure that there is not just a piece of paper that sort of facts their way, but there's an effort for there to be a conversation back and forth. We don't want to duplicate services. We don't want to undermine what's already being done. And a lot of times families just don't understand or know. So however we can facilitate communication with their existing providers and be another sort of way to help the family understand the direction that's being recommended, that's what we want to do.
Excellent.
Not duplicate.
Excellent. And so my assumption is going to be then that anyone could refer to the UCC. So if someone's working with a client, no matter what level of care they are at the point, and they feel like, the child is an appropriate fit and the parent or the family just needs an additional level of support, they can then say, hey, why don't you check out the Village's UCC for some additional support? Or are you seeing this more for providers as a step up option versus a step down option? Amy, you can go.
I think that's a good question. I was going to just add on to something that you said, Yvette, as we're doing a lot of presentations and talking about this new level of care, and I like to kind of say new level of care on purpose, right? Because it is brand new, and that's where that gray comes in. And one of the things, the comments that I was working with some school staff on, they said, is this the urgent crisis center? Is this only for kids in current crisis? And I explained, and they asked specifically, what if I have a child who I'm concerned about? Can I make that recommendation to the family? And I said, absolutely yes, right? It's not just about the kids in current crisis. If there's a child that you're concerned about, you don't need a referral to come to the UCC. Just have them come. It's better to walk into the UCC and get that comprehensive assessment and then know what services you actually need than to wait until you're actually in crisis to get that work done too. Better work happens, just as much when you're not in crisis too. So I want to kind of make sure that people understand you don't need to be in current active crisis to be able to seek the UCCs as well.
Excellent, because the title alone would make you believe that that's what you would have to be. And when we think about, centers for medical needs, right? It's always like if you're in a crisis situation, but I really appreciate you clarifying that and letting people know you can come before it escalates to the point of no return. So we have an audience question, and so I will ask that question at this time. Thank you for the audience member who posed this question. How are you assisting patients that are undocumented and don't have access to insurance coverage? Dr. Taylor, you want to start?
Yeah, thank you. So there is no kid that can't be served at the Urgent Crisis Center. So this is a grant funded program. And so any kid or family, any youth that needs the support can walk in. It doesn't matter about documentation status, insurance status, diagnosis, neurodevelopmental ability, disability. None of that matters. We're here to serve all the children of Connecticut.
Excellent. Amy, anything you want to add?
No, she answered it perfectly.
So pretty much all inclusive, right? There is no child that will be left behind, no door will close for any child that access us or any families that access us for the needs of their children. And I'm glad, as I said, that the audience member asked that question, because sometimes folks don't know. And sometimes they err on the side of caution and don't seek the help that they need because of fear that it may lead to more issues for their family and more trauma for their kids. So we just really want to emphasize that for anyone who falls within that category, the village is a safe place. You can bring your children here for treatment. You can get the care that you need without fear of retaliation or feeling like something will happen to you or your child. We are definitely committed to the well-being of all children. So we just want to make sure we emphasize that strongly for individuals from that community. So as we getting close to the time, because we have about 3 minutes left, so just never enough time to have these rich, robust conversation. There's 2 more questions, ladies, I want to ask, unless another audience question comes through, is talk to me a little bit about the therapeutic interventions. Like, Amy, you mentioned the rooms and this, soft and comfortable, seating that's there. It's bright, it's vibrant, it's beautiful, because I've seen it, so I can comment on that. So it's a warm, friendly, safe, calm place for families to come in. What are some of the therapeutic interventions? What are some things, there's some kids that might need a weighted blanket for an hour or half an hour, for self-regulation purposes. What are some of those strategies other than just triaging and connecting? Are there some therapeutic elements that, it would be nice for families and parents to kind of know could potentially be a part of the work you're doing with their child? Amy?
Yeah, Yvette, you talked about, for example, weighted blankets, right? So when a child's in crisis or family's in crisis, we know sometimes just space and time, right, can help a child regulate, whether it be the parent or the child. So we also have in our UCC 3 sensory rooms, and these rooms are intentionally designed for kids with multiple, different challenges. So number one, they're just bigger spaces, right? So they have different interventions like a sensory walkway where kids can get their physical needs met. Maybe they just need to do some physical things to help ground them. There's also therapeutic chairs, therapeutic rockers. If you have a child who just needs to ground themselves in something and they're very, very anxious, we have found that if you lay and you rock in one of these rockers and you use a therapeutic blanket, for example, it is incredibly soothing. And if you do this for, 15, 20 minutes, you're at a different place to be able to do certain work. We had a child that was incredibly dysregulated and was bouncing from different activity to different activity. And he was doing this for multiple times with staff and with supervision and with support to guide him through some of these activities. And he did this for quite some time, about an hour. And then once he was able to do that, more work happened because of some of those therapeutic interventions. So I think we have really qualified staff to help guide kids, utilizing whether it be therapeutic toys, therapeutic furniture, different focused activities, mindfulness activities, for example, to help kids decompress and connect with the work that has to be done.
Excellent. Thank you so much for that, Amy. So we're going to wrap, but I want to ask you guys one question. If you had someone walk up to you and say, hey, I think my child is going through an issue and I really want to access the urgent care center, what's your quick commentary to that parent, to that individual, to make them feel like this is the place for them to be? And then in that conversation, how do you tell them they get access to our services? So Dr. Taylor, I'll have you go first. This is your elevator pitch.
Yeah, I would start off by telling that parent that we're here for you. And that however you need us to be here for you, we will be here for you, inclusive of being able to just provide advice, support, that kind of thing. And then how do you come? You just walk in. There are different hours for the different locations. So I would suggest that you look to be updated on the most, updated hours for each place. But for example, the Village's urgent crisis is open from 7 in the morning until 11 p.m. Monday through Friday. And the last assessment we'll take is at 9 o'clock, but we will never turn anybody away. And even if they come close to our hours, we will provide support, because the aim is to do what we can to provide support.
Excellent. Amy, any last minute comments or your elevator pitch?
No, I think I would always tell families that just come. We're a safe place and we will meet you where you are, period. To get access to us, I know Dr. Taylor said that, and look at our website, because our website will give you our address and our current hours as well.
Excellent. And that website is going to be put in the chat, so that if anyone needs to get access to that, it is available in the chat. But in general, it's thevillage.org/UCC. For anyone that's listening to the recording, just so you have that information. Thank you so much, Dr. Taylor and Amy, for taking time out of your very busy schedules, because I know both of you are very busy women here at the Village, to have this, conversation with us today. I appreciate both of you so very much, and the work that you guys are doing here at the Village and the impact you're having in the lives of members of our community. So thank you for your service. Before we close, I just want to let everyone know that our next episode of Lunch Break will be in October, and our focus will be on climate and environmental anxiety. So please tune in. That's going to be a really good conversation. We're going to be talking with an environmental activist / attorney, and really learning about how all the climate and environmental issues does have an impact on overall mental health. So please join us for that episode in October. You can always check us out on Facebook, Instagram, or LinkedIn to get more information and updates about upcoming events, and also to see any previously recorded episodes. We do have a landing page on the Village's website, so you can also find previously recorded episodes, and or you can share this through Facebook with anyone that missed this episode that you think would benefit from hearing more about our UCC program here at the Village. As always, thank you so very much for supporting us, for tuning in, and as always, be well.